A very good evening to all of you. And in this particular video, we will have a look at some of the key points in the insertion of cervical pedicle screws. Now, we all know the indications for cervical pedicle screws. They are basically used as bailout options in case of lateral mass blowouts or in cases of where we cannot insert lateral mass screws like lateral mass dysplasia. In congenital conditions where there is absence of lateral mass and probably the pedicle screw is the only option for you to get a good hold, and in cases of deformities and long fixation where again you want a very good hold at the end of the construct. Now, if we talk of the technique, more than the execution, it is the pre-operative planning which is extremely important in cervical pedicle screw insertion. And here we have to consider 2 points. One is what is the normal anatomy and the challenges which we might have to face because of variations in the normal anatomy. So if we look at the cervical lateral mass, it's basically a rectangular block right from the superior to the inferior articular process. And on the lateral margin, there's a depression at the proximal 1/3, which is called as the notch. And exposure of this notch is extremely important for you to insert cervical pedicle screws. It is basically down the slope at the lateral aspect of the lateral mass. And the entry point, which was described by Abu Mehmet al in 1997, is exactly related to this particular notch. It is 2 millimeters medial to the notch and slightly proximal at the junction of the superior and inferior articular process at the superior level. Again, there are variations in this depending on individual pedicle angulations. The entry point might vary, and we have to plan each and everything individually, although this is a rough marker. So a CT scan, axial CT scan at each and every level is extremely important. As you can see over here, the pedicle variation can change from 30 degrees in the mediolateral direction right up to 70 to 80 degrees. So each and every pedicle has to be calculated on the pre-operative axial CT scans. We also have to look at the relation of the nerve roots and the vertebral artery in the cervical pedicle. In the lumbar spine, the nerve root exits inferior to the pedicle, whereas in the cervical spine, the nerve root exits proximal to the pedicle or superior to the pedicle. This is an important point that we should consider, especially if you are erring on the side of screw insertion. Also, the vertebral artery is right in front of the lateral mass, the entry where you get where you take for the insertion of cervical pedicle screws, and adequate medial angulation is extremely important. There is normal variation also as we move proximally from caudal to the cephaloid direction in the cervical spine. The vertebral artery foramen moves posteriorly and medially, which essentially means that the dimensions of the pedicle become smaller as we go from inferior to superior. Also, the angulation will change more medially as we go from inferior to superior. So these points should be remembered. The abnormal challenges are related to the vertebral artery foramen. Sometimes we can have enlargement of the foramen or aberrant vertebral artery. The most common is the sclerotic pedicles, wherein the incidence is almost 25%. And if you don't pick up these sclerotic pedicles, although there's a way of putting a screw in the sclerotic pedicle, but it's extremely risky, better to avoid it, and you can consider some other options like a lateral mass, or you can just skip the level and go proximally and distally. And the other is the dysplastic pedicle, obviously where you cannot put in pedicle screws. Hence, in each and every case of pedicle screw fixation, it's extremely important that you get a CT angio and an axial CT at each and every level. Regarding the execution, it's not a bad idea to play with the implants that you're going to use, especially try to make out what is the angulation between the tulip and the shaft of the screw. If it doesn't allow too much of angulation, then you might struggle to put in the rod at the end of the surgery, especially if you're planning a junctional surgery, like you're planning a C7 to D1, then you might struggle to connect the cervical pedicle to the D1 pedicle screw. Other instruments which I like to use are a small 90 degrees ball tip probe. In case I am in difficulty, I might do a small foramenotomy with the kerosene ronger and palpate the pedicle from inside and put in the screw. A straight ball tip probe, a rigid one, is extremely important, which glides along the medial margin of pedicle wall, along the medial margin of the pedicle wall, which is supposedly the strongest wall of the cervical pedicle. Now, regarding the execution, this is the intraoperative picture where you can see that the entry point of the cervical pedicle is quite lateral and superior as compared to the standard lateral mass screw insertion entry point. The steps are pretty much the same that we do in normal pedicle screw insertion. You need to have good amount of mediolateral angulation. Here you can see that I don't use a self-retaining retractors. I usually use a Dever's retractor, which allows me to press down and laterally onto the soft tissues so as to get the desired amount of medial angulation so that my probe can go and hit the medial wall of the pedicle and glide accordingly. We need to check the standard 5 points: the medial wall, the lateral wall, the superior inferior wall, and the anterior cortex. I usually prefer the screws right up to the anterior cortex because it gives me a very good hold. And again, while putting in the screw, it's extremely important that you have enough of lateral retraction, pressing down on the lateral structures, pressing anteriorly on the lateral structures so as to allow you good amount of medial angulation. The same thing can be repeated on the opposite side, and then obviously you need to check on the Shyam. We have found out that the AP view is not much of much importance. It is the lateral view which gives a good orientation, and a perfect pedicle screw, according to me, is the one which goes and hits at the tip, at the anterosuperior corner of the vertebral body. So that's a good screw. So overall, it's a very good technique to have in your armamentarium. You can combine, mix and match with lateral mass screws. You can combine this with anterior fixation. If you plan it well, the anterior screws have to go slightly at the lower level. So you can mix and match and give a very good construct as far as the cervical spine tricolumn fixation is concerned. Thank you very much for your attention.